Top Med Talk.
Hello and welcome to Top Med Talk. I'm Desiree, Chappell, your host, and we are covering the COVID-19 pandemic and crisis from the front lines. Our conversations in the past week have spanned the globe, and we're going to continue to bring the latest updates as long as we're able before being called into action ourselves. Now, normally I'm joined by our editor-in-chief, Monty Mythen, but if you've been following us on Top Med Talk, you probably know that Monty does have the coronavirus. He was diagnosed officially about 4 days ago. He's about 7 days in now. So, Monty, we're sending you well wishes for a very speedy recovery. Get well soon because you're my wingman. I always call him my partner in crime. We're waiting for you. So, get well soon, please. Now, much of what we're seeing on the news outlets may or may not be actually representative of what's happening in our hospital and with our healthcare providers. And, if you look on social media or any of these different sites, you'll see accounts of clinicians, nurses, and doctors telling their stories or talking, reporting about what is going on. But our mission is to go straight to the source and speak with our guests, those who are in the trenches, the soldiers, to give us a firsthand account of what's truly happening. So joining us today, we have Roneet Lev. She is the Chief Medical Officer of the White House Office of National Drug Control Policy. But today we're talking to her as the Director of Operations from the Scripps Mercy Hospital Emergency Department in San Diego. Roneet, thank you so much for taking time out to talk with us here on Top Med Talk.
My pleasure and honor, Desiree. Thank you.
Roneet, I did introduce you as the Chief Medical Officer of the Office of National Drug Control Policy.
I do carry that title, but for today and for the purposes of this talk, I am reporting on the ground, the frontline soldier as an emergency physician, and not with my role in drug policy.
Gotcha. Every time we're talking, you're always saying that you're doing double duty because you have these things with the drug control, but you are on the ground in the emergency room there in San Diego as an emergency physician. Tell us what it's like there on the ground right now.
So as soon as we kind of got word of the pandemic, I realized that my job is here on the ground where we need to be. When the pandemic first hit, we were out 3 physicians right away for quarantine, and the manpower was needed. I actually feel that our most precious national resource right now is emergency physicians, not masks or visors or even ventilators. But if we don't have the people on the ground to take care of people, then the whole community is out. The joke among emergency physicians is stay home unless you want to get intubated by a radiologist.
That's right. I know. There are several of those memes going around. I think they also show the laryngoscopy blades, the Mac or the Miller blades. And it's like, if you don't know what this is, stay home because you don't want it. Roneet, tell us, do you have anyone that's out right now in your emergency department that's tested positive with COVID?
That's what's so strange about the virus, and I wish I would understand it better. We do have our very first physician, the first physician, I think, in all of San Diego County for civilian physicians, because I think there were military physicians who were out as well. So he was out with corona. My best health wishes to Monty. I don't know how it goes, but for our physician, he was out. He felt bad maybe for 2 days and recovered. And yesterday he was working in the shift, and we very smartly put him in the COVID zone, hoping that he has some immunity. He already volunteered to have his blood donated to have, vaccine made from him. And so we have that. And then on the other hand, you have someone who's same age, a respiratory therapist in our hospital who is on a ventilator. And I just don't understand why someone gets a mild case and others have horrible cases.
Yeah, it's going to be interesting how all of that's going to come to light, hopefully in sooner rather than later, to really determine what the risk. I mean, we know the risk factors, but really what is pointing to the severity of the case. Roneet, tell me, there in your ER, it sounds like you guys are not seeing the influx in it heating up necessarily from our previous conversations as, say New York or other parts of California. Can you tell us about what you're seeing come in?
We did not heat our peak. The emergency department, before the state of California was shut down, we had a big surge. We had to call in extra doctors. And then almost the next day, the place was very quiet. We put up our COVID cabana, as we call it, to have people come in and be treated. And now we have 2 of them out in front of the emergency department. So people are triaged from the front and either sent to the COVID cabana, to the inpatient. We have inside the emergency department, we have an entire wing that's all negative pressure, or to the main emergency department. But as any emergency physician or nurse would know, people don't necessarily present with their diagnoses.
Right.
So really, I tell our staff to treat every single patient as if they are a COVID patient. Someone comes in with the trauma unit, they come in with the ankle sprain, they cut their finger cooking. You have to really consider that they may be carrying the virus because they could be asymptomatic.
Mm-hmm. Yeah, that's very true. I think that, many places across the country and globe really are trying to do that with all patients, just assume that they all have CV and treat them. The patients that are coming in that you are seeing that have COVID, I mean, obviously you said there's always a degree of severity of the illness. Are you finding that people are staying home a little bit later now that we understand how the disease might be progressing? And so you're seeing a lot more severe cases come in where you have to do emergency intubations as soon as they arrive. Where are you seeing that?
We see the whole range. The COVID cabana is supposed to be the people who are not as sick. So we may do a nasal swab and send the COVID test and have them quarantine. The problem is those tests, I'm checking my patients from 10 days. There's even more of a lag. I say that the patients that we're testing will either live or come back without even knowing their test results. So the numbers that we see, even at least for San Diego, will have a major lag. What happened at the beginning, we were testing a lot of people. We were, say we had the drive-through testing and we had the cabanas, and then we ran out of material. So then we reserved the testing just for the sicker patients. And now we just have replenished our supply for outpatient, but the timing for testing is still very behind. For those who are admitted, we have the quicker test. It comes back within 8 or 18 hours. It's batched twice a day. So we get those results faster for inpatients. And we're seeing the range. If your O2 sat is okay and you just are feeling bad, then you're outpatient.
Yeah.
If you're hypoxic, then you get admitted. And then you see the mix is typical in the emergency department. People don't present with the diagnosis, tattooed on their forehead, right? I'll have somebody who's weak and dizzy, and later we find out, yes, they had a cough and maybe they are positive, or a dialysis patient who developed a fever during dialysis, and then they turned out to be a STEMI, and then they're being tested for COVID. And so all right, that's life, the real life in the emergency department.
Absolutely. I think some of us take for granted whenever we're working in the critical care and anesthesia. We're beyond those early diagnoses.
And to make things more complicated, San Diego houses the 4th largest homeless population in the United States, 3rd largest for veterans. And so we have what I've termed the COVID hotel. If we have patients that we think may be carriers, we can't send them home to the street. We keep them. And then here we have a dilemma. On one hand, we don't want to waste this precious test that we have for inpatients. That's the quick test. On the other hand, what happens if you don't use the quick test is that they may sit in the emergency room in those precious negative pressure beds waiting for a hotel room to be available. So we're kind of working through those issues as well.
Are the local authorities there working with you guys to manage this? How's that going?
Absolutely. I'm very proud of our public health department. Our epidemiologist is an emergency physician who understands what it's like to be on the ground. And so we have a very good team. But anytime you learn anything new, to think of any new skill anybody has, whether it's learning to paint or computer program or anything, that's what we're doing on the ground. Yeah. So for anybody to say, oh yeah, we're ready, nobody's ready until you're dealing with it and learning things, and things change and then you have to adjust. And that's just the way it is. But yes, our public health department is amazing as far as getting this hotel and thinking about the homeless population and giving us data in real time as far as number of cases, who's in the hospital, who's in the ICU, what are the ages. As a physician, I'd also want to know more, like how did they get it? And why is this person worse than the other? And really understanding that so I could prevent and treat better.
Yeah.
So we're getting, I think, a lot more information than most people. We're also thinking creatively, such as we have a very large psychiatric population. And before the pandemic, around the country in emergency departments, we are holding psychiatric patients for days. We call it boarding. I call it living in the emergency department. Psychiatric patients were living in the emergency department, waiting for an available bed. And we started this pandemic, things were the same. They're waiting in the hallway and thinking like, hey, now if they came COVID free, maybe they won't come out of it COVID free. And so they're trying innovative ways of diverting mental health patients without COVID symptoms to a different complete part of the hospital and not avoiding the emergency department. We're trying that in one of the hospitals in San Diego, and I hope that's successful. I think we'll find, I hope at the end of all this, there'll be some innovations that would be great ideas even when the pandemic is over.
So the hotel that you guys are using, I was just interested in that because I've heard that came out of Washington, they were starting to put their COVID patients in hotels. Is it an actual physical hotel that they've taken over to have the homeless people shelter?
Yes, I believe that the county bought it and has that.
Yeah. Wow. That's amazing. You talked a little bit about the amount of testing that you guys are doing. So you have plenty of tests in line. Have you heard any more about even more rapid testing occurring? So the 5-minute test or 15-minute test that you'll know results?
We get several emails on all the subjects several times a day. And as I'm sure like everybody else, it's hard to catch up with. We have the inpatient test. I don't know if it's quite 5 minutes. And if it is, it's batched twice a day. So it wouldn't be 5 minutes anyway, because it's not run all the time. And so we are using that only for the inpatients because we have a limited supply.
Yeah.
For the outpatient ones, we're doing the testing, but the lag is 10 plus days. I have patients that I tested. I try to check to see where they are, like how many patients I personally treated. March 18th, I still don't have those results back.
That's crazy. I don't know what else to say about that. Wow. Well, do you just still treat them as they have it? I mean, I know that you
tell patients, just assume that you have it. Yeah. The result will not come back for a week or more. And so please treat yourself like you have it, with precautions for infecting others and instructions of when to come back to the emergency department.
Yeah. Oh my goodness. Well, Roneet, I was wanting to know about your ICU capacity, the amount of people that you have on ventilators, and if you feel that, have you created different care areas and spaces for overflow? What does it look like inside your hospital?
We have not reached our peak. So right now we have ICU capacity and we have ventilator capacity. But again, we haven't reached our predicted surge that is to be in April. And so there's discussions about that. I think that the county has discussions, nurses, hospital committees. I've seen around the country, well, what do we do if we run supply? Do we need to make difficult decisions as they have in Italy? Who's going to live and who's going to die? Those conversations really disturb me. I don't like to think in a negative way like that. I don't think that it's our ethical responsibility to make that. There's some young 80-year-olds and there's some old 50-year-olds. I think people need to be taken care of individually. And rather than thinking about who's going to live and who's going to die, I think we need to start practicing how to use 2 people for 1 ventilator, 4 people for 1 ventilator. The surgical centers that are not using their ventilators, how do we get those? How do we transfer our non-COVID intubated patients to the Mercy ship or somewhere else? I mean, I think I'd rather have those kind of discussions go in that direction and not have, life and death decisions based on 1-to-1 ventilators that we have, but we need to think outside the box.
Yeah. If there is the terminal extubation, or we know the care needs to switch from treatment to palliative, how do we support those patients at that time? Because they don't have family there. They're usually very alone. And that is what has really been getting to me.
Well, you know what? That's happening now. And it's very sad. I'll have come into the room and I'm very into including family and getting information, getting history, discharge instructions. And patients are alone in the emergency department. Yeah. I had an Alzheimer's patient. He's oriented ×1. Where am I going to get my information? He doesn't know his phone number. and the family's outside. They can't come in. That makes medical care sad, I think, all around.
Yeah, just difficult to do our jobs. I mean, we rely so heavily on families. It's a good point. Well, Roneet, thank you so much for just taking this time and sitting down with us on Top Med Talk. It is just so important to hear your experience and what's happening there in San Diego and to help inform people in other areas around the world. So thank you for that.
And thank you for hosting this, and for all the medical professionals out there. You are the warriors, the soldiers in this battle. We're proud of you, and it really brings us back to the calling of why we entered medicine in the first place. I'm very proud to go to work, and when I'm there, there's nowhere else I'd want to be. And I think there's a lot of people who feel the same way around the country.
Absolutely.
Top Med Talk.
Thank you for listening to Top Med Talk. You know, you can always find us on Twitter, LinkedIn, Facebook, and on topmedtalk.com. We want everyone to stay safe. If you have any questions or you want to talk to us on Top Med Talk, please reach out via contact@topmedtalk.com. That's contact@topmedtalk. Thanks for listening.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.